Good day. My name is Michelle Lavander, and I'm the director of the USC Center for Health Journalism and editor-in-chief of centerforhealthjournalism.org. Thanks for joining us today for our Health Matters webinar, Making Mental Health Care More Equitable, What Works? Today, we'll hear from Dr. Sergio Aguilar-Gaxiola, who is a leading international scholar, researcher, and educator on mental health and health disparities. He's also a visionary practitioner and builder who has designed and implemented programs designed to make our healthcare system more equitable for communities of color and others who have struggled to access care, especially when it comes to mental health. For many Americans, mental health isn't there when they need it. Dr. Aguilar-Gaxiola will share a model for implementing innovative community-based approaches that can make it easier for Latino, Filipino, and LGBTQ clients to benefit from mental health care that best serves their needs. The program in California's Solano County is unique because it was defined at every step of the way by community insights and input. It has led to significant increases in the number of people from underserved communities calling for appointments and receiving outpatient care rather than crisis services. The collaboration has caught the attention of the state of California and over 40 counties seeking to make their mental health systems more equitable. In this webinar, we'll explore what this forward-thinking program teaches us about the broader effort to expand access to mental health care in underserved communities. Before we get underway with a virtual room filled with so many journalists, I'd be remiss if I didn't mention that the Center for Health Journalism is currently conducting a call for applications for our July National Fellowship, which provides training, $2,000 to $10,000 in reporting grants and mentoring for journalists with a project on children, youth, and families that they've always wanted to tackle, especially if they want some extra help. Our core focus for the program, like this webinar, is health equity. To learn more, email us at editor@centerforhealthjournalism.org. We'll also put more information on the program in the chat. And now let me turn to introducing you to Dr. Sergio Aguilar-Gaxiola. He's a professor of clinical internal medicine in the School of Medicine at the University of California, Davis. He's the founding director of the Center for Reducing Health Disparities at UC Davis Health, the director of the Community Engagement Program of the UC Davis Clinical Translational Science Center, and a member of the Clinical and Translational Science Awards Community Collaboration Enterprise Committee lead team. And he's currently serving as a member of the executive committee of the World Health Organization's World Mental Health Survey Consortium and is coordinator for Latin America participating countries. He's co-chair of the steering committee of the National Academy of Medicine, assessing meaningful community engagement in health and healthcare. And he's a member of the National Advisory Council of the Substance Abuse and Mental Health Administration and a board member of the California Healthcare Foundation. So this webinar is made possible thanks to the generous support of the Commonwealth Fund, the National Institute for Healthcare Management Foundation, the California Endowment, and individual supporters like you. You can tweet about this webinar with the hashtag mental health, and we will be archiving this conversation later today at centerforhealthjournalism.org. A word about our format today. We'll be hearing first from Dr. Aguilar-Gaxiola, and then we'll turn it over to our audience for questions. Feel free to share general comments in the chat. And if you have questions or technical concerns, please use the Q&A panel. You can write us there about any other issues as well. Now let's get underway. Dr. Aguilar-Gaxiola, we're very eager to hear from you.
Well, thank you so much, Michelle. I really appreciate the kind invitation and your kind introduction as well. And I was looking forward actually for this opportunity to share some of our work with journalists. You know, I have a tremendous respect for journalists. You know, in academia, and I'm an academician, we, you know, usually tend to publish in journals. And the circulation in journals is so limited, you know, some of the best, 35,000 people, 40,000, that the work that you do reaches millions of people. So I welcome this opportunity to share this work with all of you. And saying that, I'm going to share my screen, Michelle.
That sounds excellent.
Okay, so let me see. Can you see it?
Yeah, you might just want to make it full screen.
I'm in that, on that. Okay, very good. Let me go with the first slide because it's important to be on the same page as to what we mean by health equity. And some of you may have may be familiar with healthy people that every decade is a health-related group that provides goals and objectives for keeping a healthy population in the US. So the newest edition, the 2030, has a framework and has so much information, helpful information, that if you're not familiar with it, I would recommend that you take a look at it. But at any rate, Healthy People 2030 defines health equity in very simple terms as the attainment of the highest level of health for all people. And why does that matter? Well, it is because there is this conviction that everyone deserves a fair chance to lead a healthy life, and that no one should be denied the chance because of who they are. And there are many factors that are associated with disparities or inequities, which is the area that I have been heavily involved for more than 4 decades now. So I'll discuss with you some of those disparities in a very specific example that I'm about to share with all of you. So that is why it matters. Everybody should have the opportunities to be healthy and for well-being as well. How do we work then to achieve health equity? What we need to do is eliminate avoidable health inequities and health disparities requiring short and long-term actions. And eliminate is an ambitious goal. I would settle by advancing health equity and achieving health equity in some on some specific situations. So one of the questions that I have been grappling with for decades now is this one here. Is it possible to advance health equity in historically underserved populations? And in my case, my center and the work that I do is heavily guided by community engaged approaches. So this is specifically related to what our center does, the Center for Reducing Health Disparities, which is focused on solutions to inequities, for example. So once again, this has been an elusive, no question, but the answers that have been, posed for decades. Is it possible to advance? So let me get started. And I'm going to share with you a specific example of what Michelle mentioned, work that we have done in Solano County, which is a county that is between San Francisco and Sacramento counties. I live in Sacramento, and I also was trained at UC San Francisco. And it's a kind of semi-rural, semi-urban county. And this is work, by the way, that we have done for, even though I say 5 years in the slide, which is what we received funding for. We work in this project for over 7 years now. And the funding came from the Mental Health Services Act money this is an initiative that kind of a Robin Hood initiative that taxes 1% of the raw income of millionaires and billionaires in California that passed by the voters in 2004. And since 2005, there is a fund coming from those taxes that, it translates to over $2 billion a year to improve mental health services, especially in communities that have inequities. So the money came from the MHSA Innovation Project, and we focused, as Michelle mentioned also, on 3 priority underserved populations in Solano County. And in the map, you see the 3 populations. Those are Filipino Americans, Latinos, and LGBTQ+. This work was anchored in the nationally recognized culturally and linguistically appropriate services, or also called CLAS standards, which is 15 standards, 15 standards that were developed by the Department of Health and Human Services Office of Minority Health and released in 2001. And we have been working, on using this framework for many years, actually since 2006. So we are very much familiar with that framework and received money directly from, the money went to the state of California through the Office of Minority Health, which is are the developers of the CLAS standards. The other thing is that, as far as we know, this is the first project combining the CLAS standards with community engagement. About 7.5 years ago, the director and 3 other leaders from Solano County, the director of the Behavioral Health Division, Halsey Simmons, came to see me and my team at UC Davis and asked for our help. And what they presented to us is this picture that they said, we would like to advance, to address disparities in 3 specific communities that have been historically underserved in Solano County. And they presented to us this data here. And this is service utilization, or who is using services in Solano County. At that time, it was data from fiscal year 2010 all the way to 2016. And as you can see in this diagram, there are 2 populations that were historically underserved, and those are Latinos and Asian and Pacific Islanders. But in Solano County, it meant Filipinos. About 76% of the Asian and Pacific Islanders in Solano County are Filipinos. Actually, Solano County has the highest concentration on percentages, not only in California, I'm told that in the US as well. So this is what they presented to us, and they said, we have been working for the last 3 years with community leaders to try to make progress, but we haven't been able to do. Would you help? And of course, we really jumped to this opportunity because, this particular project has brought to bear all the knowledge that we have accumulated up until then in a project that was fascinating to us and continues to be fascinating. So they asked us, would you, if you're interested, and we were, can you come up with a framework that you will follow in order to do this work? And we created this framework, very simple, 3 phases. Phase 1, as you can see there, is about comprehensive cultural needs assessment, which meant going especially to do a series of key informant interviews, focus groups, community forums with members of those three communities of focus. The second phase is about the development and facilitation of a specific to Solano County, a class training. And the number three, it was to implement a series of quality improvement plans, or we call them also action plans, and also focus on sustainability, which, by the way, we focus all around since the go with this project and any other project, especially working with community-based organizations. The other thing that I want to emphasize is that we use the quadruple aim. This is a widely used approach, not only here in the US, that was created in the Institute for Healthcare Improvement that Dr. Don Berwick in Boston has been developed, and they have been disseminating all over the world. This one, they originally call it the triple aim, but more recently, they added provider experience to the other three aims that you can see here. So this is what we presented to the leaders from Solano County that came to speak with us. And they said, why don't you come and present it to our community partners, which we did. And they liked it, and then that's exactly what we use since we started working in Solano County. So these are the project goals that we have. With the communities of focus, we strive to improve community engagement and partnerships. Also to increase awareness of mental health services for those three communities of focus primarily, and then to reduce stigma, mental health stigma, because it is the most important factor about not seeking mental health services. So stigma or shame about mental illness is a big issue that need to be addressed. Also, another goal was to improve the quality of the delivery of services. And when we got started working with them, it was class-informed care. And then the third one was related to the quadruple aim, which is to improve on the experience of those being served, to get them satisfied with the services, improve outcomes, and I want to be speaking to you about the outcomes, specifically increasing access and service utilization, also to improve the experience of the providers. It is very important to have a very engaged and the providers that they feel also that satisfied, that services that they are providing. And all of this while reducing costs. Sometimes it's tough to do it, especially when you are doing several things, trying to improve the quality of care. Very quickly, this was a project with lots of community focus. It was community initiated, actually, and we work specifically with these three communities that you see in the screen. Fighting Back Partnership that focus on Filipinos. This is based in Vallejo. This Solano Pride Center based in Fairfield, focused primarily on LGBTQ. And then Rio Vista Care, which focuses in Latinos and is based on Rio Vista, a small city in Solano County. Very quickly, I won't say too much in these next three slides, because one key question is, well, what do you guys do, that led to the outcomes that I will present to you soon? Well, in terms of the first phase, which was about the community needs assessment, what we did was to collect stories, to look for the history of these communities of focus, in seeking and receiving mental health services. And also we look actively for assets and for strengths of the three communities. So we did a bunch of key informant interviews, as you can see there, focus groups, community forums, identify the challenges with the behavioral health system, and also develop community narratives documenting the needs of these three communities that I mentioned to you. And by the way, we had a very, very cohesive, articulated evaluation component that started right from the go. And an important thing for me to mention is that the metrics that we used didn't come just from us, academicians, researchers, but also we very much use metrics that matter to the county and that matter to the communities as well. So we had a well-balanced set of metrics that if any one of you is interested, I'll be happy to provide you with what is it that we did specifically in terms of the measures. This is what we did from 2017 and 19. We developed a class training specific to the health and mental health needs of Solano County. And we used actually what we learned through the key informant interviews, the focus groups, the community forums that we did in the first couple of years. And we used that for the specific training that we did. And as you can see on the slide, we developed and conducted trainings, for example, something we call cultural competency 101, 102, and a train the trainer. We provided specifically providing quality care with class, which is a toolkit curriculum that we developed back in 2006 to 2009, and that we have been using this statewide, actually beyond the state as well. It's a training that we have been tailoring to the specific groups that we have trained. But in the case of Solano, we trained 3 cohorts for a total of 54 Solano County residents and professionals who develop in turn 14 action plans or quality improvement plans based on the community input that was provided to us. By the way, these residents of Solano County and professionals are representatives from different sectors in Solano County, from the county employees to members of these 3 communities that we were focused, but also there were representatives from social services, from churches, schools, law enforcement, housing, transportation, etc. So this is what happened on the second phase. This is what happened on the third phase. On the second phase, the 3 cohorts, those who participated in the 3 trainings, they were expected to develop quality improvement action plans, which is something that we have done with these trainings since 2009. So we have it very structured, and I'll give you a little bit more information about it and share with you a few photos so you see what transpired as we provided these trainings. And also, this was done with feedback from the community to really come up with positive, sustainable outcomes. So we did all of these things that you can see from, there are 4 community-based organization work plans, and this is what we did for the rest of the time. We did community forums, implementing, which still is ongoing in Solano County. And also we did other community forums. And last year, in July of last year, we submitted the final report, evaluation report, which, by the way, we updated that was in July. We updated in August and September. And I think that this final evaluation report is shared with you, or will be shared with you. Once again, I want to emphasize that throughout all of these years, the 5 years, there was this strong evaluation that began right from the go when we officially started with this project in January of 2006. So this is what we did in a nutshell. We have, as I mentioned to you, we have this providing quality care with class training. And class, of course, refers to the cultural linguistically appropriate services standards. This is the training that we organize. And this is a very intense training, comprised of 4 sessions of 4 hours each. And this is what happens in each of the sessions. The first 4 sessions, it was an overview and health disparities, specifically tailored to Solano County. And then on the second session was community needs and gaps. The third session, we started to train them on the class standards. And that's when they get started to put together an action plan. We asked them to work in small groups, 3 to 4 to 5 people for each of the action plans. And then we supported each of those small groups through coaching sessions. We met with them monthly with the idea of helping them refine those action plans so they would be ready for prime time in terms of implementation. These are some of the photos. We by design, we made it very, very interactive. We wanted them that in addition to instructions, it was very important for them to have fun as well. This is the first cohort, as you can see here. And this is Sandra Sims, who is the director of the Solano County Behavioral Health Division. And all of these people that you can see here, most of them are the participants. This is Dr. Henry Ton. At that time, he was our director of education of our center. And he was the master facilitator. He's a remarkable facilitator. And this was my associate director, Efraín Talamantes, which now is with Altamed, the largest fairly qualified health center in the US, I understand, but it's in California. It's based in Los Angeles. So this is a few photos, once again, of the participants. We really emphasize, as I mentioned to you, for them to be engaged and to have fun. So these are some of the things that the experiences that they had. Right here is Maria Lanis, who continues to be the program manager. She did a fantastic job. And we had some other facilitators like Dr. Puja, who is a psychiatrist, as Henry Tony is. So these are some of the things, once again, that happened in this first cohort. I'm the one who took the pictures, so it's from my perspective, but I think that it captures what transpired on the first cohort. So there was a graduation, and this is those that participated, and we asked them in just one piece of paper to use in one word what was their experience for this particular training in this cohort 1. This is cohort 2, some scenes of cohort 2, and this is the graduation as well from those participants. What I want to bring your attention is the incredible diversity of those who participated. My goodness, that was fantastic for all of us at our center, and for all of them as well. As you can see here, incredible diversity. She related to a church, Roxana, a leader, actually, a city councilman from Solano County. And at that time, she was working with the county. I think that it still does. And as you can see, an incredible diversity. This is cohort 3, and I was out of town when they graduated, so I don't have a picture for the graduation of this group. But this is, again, Sandra Sins, that we asked her in every single cohort to come and talk about leadership, and to speak from the heart, to really do a face-to-face with all these participants. And this colleague here, Tracy Lacey, is the program, she's the senior mental health services act coordinator for Solano County, and she has been our main point of contact. So out of these trainings, they came up with 14 quality improvement action plans, and you can see them organized here. 5 of them are community focused. 4 of them are CBO or community-based organization defined. 2 of them are workforce focused, and 3 of them training focused. And the names that you can see here are the names that the small groups that develop these action plans decided to call it. So you have very interesting names like Bridging the Gap, Taking Class to the Schools, Through Care Roadmap. With the CBOs, they took the name of the CBOs, like this one, Training Focus, Cultural Humility Champions, ICU. So I have just a few examples that I will share with you without staying too much time there. This is just to share with you the action plan that was developed by Rio Vista Care, which took the lead here. And one thing that I want to share with you is that something that emerged throughout this basically 7 years, it was the key importance of trust, of building trust. And for us, from UC Davis, being foreigners in a foreign land, we were traveling to Fairfield very frequently, which is 45 minutes from Sacramento, but we were outsiders. So it was of critical importance to become trustworthy with all of them. So one of the lessons learned from Rio Vista, the action plan, developed at Rio Vista, was is for fighting back, once again, focus on Filipinos. This is for Solano Pride Center, which is focused on LGBTQ. And once again, some of the key lessons that they learned is the importance to establish a trusted relationship with these particular community groups. One example, this is the action plan or quality improvement plan that the developers decided to call it ICU, because I have been doing research on this area, and there are populations like Latinos that very difficult for them to access care. Okay, and when they access the doors of service, my goodness, there are studies that show that over 50% don't return for a second time. And we know why. We have very good information that is related to their experiences of how they were treated during the first visit. Coming to a lobby in which they are not greeted, that is very impersonal, that they don't feel welcome, and that therefore, they don't see themselves coming back to be treated in the same manner as they felt that they were treated. So this idea about ICU was to train primarily frontline reception staff to see them and to accept them and to embrace them and to provide the best quality services that they could. These are some of the outcomes. Now I'm moving to something that is of great interest to me. Okay, what do you have to show for? Well, there are four outcomes that I will focus, even though there are many more than four. But one is that, and I'm emphasizing once again, the importance of building trust with underserved communities. It was a key factor. And the other thing is that mental health service use increased by 20% and was especially high among the LGBTQ residents. Over 300% who had traditionally underutilized services. Also from baseline, we found improvements in participants' level of cultural responsiveness, as well as improved engagement by these percentages in Latinos, in Filipinos, and LGBTQ. One thing that we also was very important for us was that these underserved communities were less likely to enter the mental health system of care. I mean, they were. It was very common that when these three communities entered mental health systems, mental health services, it was through crisis services, not through outpatient. It was when they were falling apart and they really needed to receive the services. So one of the outcomes that was really heartening for the county itself was that there was a significant decrease in first admissions through crisis services and an increase in outpatient services. These are very expensive, services. These are much less expensive services, and we suspect that outpatient services will tend to be more effective than just dealing with crisis. So you can see the decrease in the first admissions through crisis services by these percentages in Filipinos and Latinos and LGBTQ. So these trends, we believe, in discussions with the county, that reflected increased trust toward primary mental health care providers in Solano County and resulted, that we know, in substantial cost savings. Another piece of information is responses to this question. Is participation in the project associated with higher levels of job satisfaction among Solano County behavioral health staff? And the answer is that, yeah, absolutely. 98% of Solano County behavioral health staff reported that their job was meaningful. So there was an increase in meaningfulness, perceived influence, perceived effectiveness, perceived inspiration, and job satisfaction as well. Collectively, some people call this joy in work, which nowadays is of critical importance because of the burnout that is happening left and right in health settings. So going back to the original question that I posed as I started with this conversation, is it possible to advance health equity in historically underserved populations? And the answer is yes, absolutely yes. Mental health equity can be advanced, as we have documented with this particular project. And by the way, something that has been of critical importance to us is sustainability issues. We started to plan about sustainability right from the go, actually, even before we got started. And there was a serious work on sustainability in each of these areas that you can see here, about the county contracting practices, about policy development, and there are specific items within each of these categories. The continued implementation of quality improvement action plans, in hiring and retention and diversity and equity planning and committee. There is a committee that was developed because during the pandemic, you may remember with the murder of George Floyd, that really triggered a widespread unrest. The same thing happened in Solano County. So they created this diversity and equity planning committee that has been extremely active. Also, very important, interpreter and translation services. As Michelle mentioned in her introduction, we are now scaling up to over 40 counties that have signed up in California through what we call a learning collaborative. So it is not only a learning collaborative, we are also going to have 2 training cohorts to these over 40 counties. And we are going to develop 4 mentor-mentee relationships with actually 4 counties. And it is, can you imagine Solano County, as small as it is, less than 600,000 people, is going to be a mentor to the massive Los Angeles County, but also 2 counties in the Central Valley, Kern and Fresno counties, and also Marin County, which is in the Bay Area. And these are the topics that we anticipate that we're going to train the 2 cohorts of over 40 counties, maybe by when we are about to get started with this in the next few weeks. We're getting ready for that. We're going to have 50 some counties. There are 58 counties in California. So we're happy that more than 40 have signed up, but it would be great to have as many counties as possible. So these are some of the topics that we are going to be addressing. One topic that for the county has been of critical importance, as they have told us repeatedly, is the importance of training them on how to engage communities in a meaningful manner. So 3 of the training workshops with lots of exercises are going to be on community engagement. But we're going to be speaking about the impact of COVID-19, the social determinants of health, and other determinants as well. We will speak about implications of trauma on marginalized communities. We're going to train them heavily also on the class standards, equality improvement, and then the very important topic of sustainability. By the way, a little bit of bragging here. I don't know if you are familiar with the American Association of Medical Colleges. This is a very powerful organization that approves medical schools across the nation here in the US. And they recently gave us second place for our project in Solano County. And by the way, I haven't even told you that the name of the project is Interdisciplinary Collaboration and Cultural Transformation Model Innovations Project. This is the name that the county, not the county, the community partners decided to call it. Okay, so we are following their lead. And it is just very gratifying to have this work recognized at the national level by an organization such as the AAMC. This is just a screenshot of our evaluation report. And this is going to be provided to you, so you can click on the reference right here on the link, and then you will be able to download it. And also we have it in a Flipbook format. I didn't know about these Flipbooks before this, when we release the final report, but it is available in this format as well. So to wrap up, I have been doing work on building community programs for over 40 years. Actually, my training on my PhD was on clinical community psychology. And there are some lessons that I want to quickly share with you that for me is something that I have learned along with all other colleagues across the nation who are leaders on community engagement, like Lloyd Michener, that I borrow some of these bullets from him. Multi-stakeholder community partnerships are required. It's of critical importance to use a health equity lens. It's so important to listen attentively to all, is to shut up and listen to the people, especially those who are in need of services. Of critical importance to review local data and to connect dots and look for the gaps. Actively look for community assets, strengths, and resilience, and use them. I cannot tell you enough what a lesson this has been for me, because I do population-based studies as well. And we usually tend to look for deficits, symptoms, for syndromes, for disorders. Very rarely we have been able to balance that with looking at assets and strengths and resiliency, which are so important. Also, to design and implement for sustainability right from the go, as I have been emphasizing. Just start and don't overplan. Learn and adapt as you go. I'm from an academic institution, so for me, involving students and trainees is of critical importance, but with oversight. And then the most important lesson that I cannot emphasize enough is the importance after we create we listen very attentively, then to build trust and create trustworthiness, which is absolutely front and center. So with that, Michelle, I'm going to stop, and I'm going to stop sharing my screen, and we'll be more than happy to hear any questions, comments that you may have.
Thank you so much. This is just so illuminating. We already have some questions in the chat, in the Q&A panel, and I just want to urge folks, you'll see Q&A at the bottom of your screen. If you have a question, please enter it there. I wanted to start out, though, by asking a question of my own, which is, you mentioned in one of your slides this idea that just something as simple as being welcoming and having a welcoming environment has been so important. And I found myself wanting to know, what are some of the other really concrete things you did, in part informed by your community process, that could help people understand this kind of the scope of the transformation? Like, is it certain things in the questions that are asked in the clinician intake? Is there a different kind of more thorough interview of a patient, or what are some of the other pillars in your mind to getting those results that you've seen?
Well, that's a great question, Michelle, and I can tell you that the ICU quality improvement plan was informed by this notion of a whole experience approach, which means that the experience of patients start when they are getting into the parking lot, or where the bus leaves them, okay? And certainly in the moment that they enter into the lobby and they are greeted or non-greeted, when they sit down, they look around and they see signage, that is familiar to their language and their culture. All of these are pieces of critical importance, to feel that they are being seen, that they are being respected and treated with dignity, okay? Certainly, when they have the intake, not only by the front desk personnel, but when they meet with those who make the intake, they ask specific questions, that they feel welcome, that they are being provided a service. If they don't speak English, then that they are given an interpreter that can serve bridge the two worlds. All of these are pieces, Michelle, that are of critical importance. And when these things are not happening, then it translates into populations don't wanting to come for a second time. And as you can imagine, with mental health issues, mental health disorders like depression, anxiety, substance abuse, coming just for one time, it doesn't work. This is not an infection that you come and you get antibiotics and God help you. That's it. They can get much better. These are conditions that require treatment at least for 6 sessions. So coming just once, it won't help. On the contrary, it is often counterproductive. Did I answer, Michelle?
Yeah, no, thank you. And let me turn to some of the questions that are already here. I'm going to read you one from Marga Pares Arroyo, who's a journalist in Puerto Rico. And she says,
right.
Excellent presentation. Her question is, how do you build trust from scratch, especially when you don't have any links or people that can make the connection with the communities?
Yeah, well, that's a wonderful question once again. There are so many different things that come to mind because this is an area that I have worked for decades. But there is a book that you can get, and by the way, is in English and Spanish, and has been downloaded close to 10 million times, believe it or not. This is work that started by the CDC here in the US. It's called the Principles of Community Engagement. Principles of Community Engagement. And, and this gives you instructions as to what to do before you connect with those communities that you want to work with, what to do during the time that you are working with them, and then thereafter, And I can tell you that this issue about trust and trustworthiness had become so important, especially during the pandemic, that now from the second edition that has been available since 2011, and the first edition, which was published in 1997, and then the second edition, there were 9 principles of community engagement. Now we're working on the third edition, and we included a 10th principle, which is trust and trustworthiness. Stay tuned because this is going to come towards the end of the summer. I'll be more than happy, Michelle, to provide, a first installment of this National Academy of Medicine that has worked on this for 3 years now. And also to send you, Michelle, as soon as it comes out, the third edition of the Principles of Community Engagement to share them with our colleague from Puerto Rico and from other places. It is amazing that, once again, the Principles of Community Engagement has been downloaded almost 10 million times. I cannot believe it. And it has been over 170 countries in English, and I don't know, 70 countries in Spanish, which is phenomenal, I think. But a fantastic question.
And I'm going to turn to a question from Wendy Brennan, who says, how do you address workplace issues, lack of psychiatrists, particularly child psychiatrists, and licensed social workers?
Oh boy, that's putting a finger on the pulse, because here in California, there is a serious shortage of psychiatrists, certainly child psychiatrists and geriatric psychiatrists as well. So it is, for some counties, has been extremely difficult to attract and to hire, have a psychiatrist on staff. And there is a lot of, cannibalism, which means that some, psychiatrists in some places are being snapped by other places, and they go to where they pay the best, One thing that we are working very actively is on digital health equity aspects, is to provide mental health services through digital pathways, okay? And to do it in a way that when someone requests a specialty care, let's say in psychiatry or child psychiatry, and that care is available through telehealth, and there are many different ways to do that in a matter of, you wouldn't believe this, in a matter of minutes. You know, I just had last night a couple of sessions with you know, our leadership at UC Davis, because we got funding from an earmark, a congressional earmark, to a project that is called Digital Health Equity Project. And it is to provide what is called express care to anyone who requests the care, no matter where they are, okay? And guess what? From the moment that they request the care to the moment that they receive it is about 30 minutes. My goodness, myself, when I have gone to my primary care and say, I want to see an endocrinologist, they said, okay. And it has taken me over 2 months, I mean, 2 months and a half to get a visit with them. Just imagine what a game changer would be to have this specialty care available just through certain portals, you know. So we are working on that already. Actually, there is the existence of a program that is Express Care at UC Davis. Google it, you will find it. And this is going to be a game changer. And mental health is one of the specialty care services that is being provided.
Thank you. That sounds fascinating. I'm going to turn to a question from Danica Peterson. She says, what were some successful methods of recruiting for the, I'm not sure, for the focus groups and forums?
Yeah. Well, excellent question as well. This is related to trust, by the way. It is one thing that we really did very consciously is to allocate a lot of time to build relationships, is to show up, you know, and be with people and talk with people. And then through community brokers, you know, which are in this case, promotoras who are very well known in the communities, is to, you know, ask for their help and to really, you know, convene meetings in community settings that are non-threatening. It wouldn't help, for example, with Latinos to have a meeting at the police station or close to the police station, with all the stuff that it happened, especially in the past administration, you know, because things like public charge and other issues that really scared communities away. But it is once again through building trust, being trustworthy, and just speaking with people, relating to people, and asking for their help.
We have a question from Lee Romney. She's a California journalist. She says the increase in outpatient utilization for the LGBTQ population is particularly striking. Can you share your thoughts about how bias and discrimination against transgender people in particular causes mental health crisis, and bias and discrimination among healthcare providers compounds that? And did you collect any data on the transgender client base in particular, or just LGBTQ as an umbrella category?
I love your question. It's a fantastic question. And what I can tell you is that definitely there is discrimination and there is a stereotyping. It is, you know, a population that absolutely needs the most care that we can possibly give. We work with Solano Pride Center and other organizations who, through the pandemic, they have continued to hold meetings with youth. They have youth groups and they have older adults groups. I just had this past week, I had a meeting with Jonathan Cook, who is the executive director, and we caught up and he gave me examples of the incredible discrimination that they continue to have. It is not I just saw an article yesterday about, or this morning rather, that says that factors that had a significant impact on LGBTQ and transgender, populations that increase suicidal thoughts and behaviors, increases anxiety, increases stress, are feeling discriminated against, as well as a series of other factors. So you bet that is a problem. And one of the things that is being done, this work is ongoing in Solano County, that being helped through the Solano County Pride Center and other groups, that there is a lot of focus on the services being provided to the LGBTQ and also transgender. And it is not by accident that the number of access calls that that the county saw for the LGBTQ population or the community increased threefold, and in some cases sixfold, 600 times increases. And I think that is related to, by word of mouth, excuse me, that they speak with each other and they said, hey, in this place, they seem to be sensitive to the issues that we are facing.
We have a question from Jody Hansen. She says, congratulations on your great work. Do you think some of the tactics used in Solano County could be replicated in rural communities where the underserved people are simply living in underpopulated areas? If so, how would you envision that?
Yeah, well, I also love this question because a lot of the work that we do in our center is precisely with those populations. We have 5 funded COVID-related projects at our Center for Reducing Health Disparities. And the 5 have significant aspects of working with farm workers and their families. And, working not only in Spanish, but also in some indigenous languages like Mixteco, Zapoteco. You know about that work, Michelle. You had followed that up for years. So yes, I had been actually very active during this couple of years during the pandemic, that farm workers, not only they have experienced excess mortality more than any other sector, by the way, essential sector, but also among community groups with the lowest vaccination rate. So we have 8 mobile units that are providing testing and vaccinations for these communities. But in addition to that, we ask questions as to whether they are in need of mental health services, because we know that they do. Last Monday, not this Monday, but the past Monday, I spoke with nearly 70 promotoras at night, through a talk that is called Pláticas en Confianza, trusting conversations. And I spoke about mental health issues. And Jesus, we were scheduled to be there for an hour and a half. And it was 2.5 hours. And I was so heartened to see the level of interest in talking about the experiences that they are having, and so there is a tremendous need for services in rural, historically underserved communities. And we need to be much more responsive about that. And we are exploring, projects in which we can provide those kind of services. One of them is through the digital health equity project that I just spoke about a few minutes ago.
We have a question from Murdy's Hayes, who's a freelance journalist in South LA. And he asks, how can community outreach better help the underserved access mental health services? Among homeless people, becoming a trusted community partner can be difficult.
Boy, yes, yeah, that resonates very much with me as well. Is one of the most underserved, misunderstood, I think, populations. In the testing and vaccination efforts that we have, as I mentioned, 8 mobile units. A good chunk of that we are doing currently to homeless populations in the Sacramento and Yolo County areas. But there is much, much more need. Thankfully, in California, we have an incredible mental health champion that is the main architect of the Mental Health Services Act, which is currently the mayor of Sacramento. That is Darrell Steinberg, who used to be the Speaker of the Senate, and it is through his, relentless work that the Mental Health Services Act, that used to be called Proposition 63, you may remember that, Michelle, and that it passed, the voters, we passed it back in 2004. So the work that Steinberg has been doing, and there is a Steinberg Institute, by the way, it's a policy institute that they have devoted their time and efforts to the homeless, to homelessness. So if you Google a Steinberg Institute, you will find a truckload of stuff related to homeless, to dealing with effectively with the homeless population.
And we have a question from Carla Denner. She asked, did increasing the awareness of mental health services and decreasing mental health stigma and the trainings include substance use and abuse awareness and services?
Yeah, it is behavioral health, and behavioral health is an umbrella term that encloses mental health and substance abuse. So it is mental health disorders like depression and anxiety and psychotic disorders, but also substance abuse and dependence. These are two. And one of the characteristics of this mental health and substance abuse or behavioral health is that the comorbidity that exists. So the comorbidity, meaning that those who suffer from depression tend to also have problems with alcohol dependence, for abuse and dependence, for example, or those who suffer from anxiety disorders tend to be depressed as well. So there is this co-occurrence of these conditions, which is the rule, actually, rather than the exception. One of the tragedies here in the US in terms of substance abuse treatment is that there is incredible inequities. I mean, incredible inequities with Latinos, African Americans, Native Americans, especially for those who are in need of services for substance abuse problems. I cannot emphasize enough. As Michelle mentioned, I'm a member of the National Advisory Council of SAMHSA, the Center for Mental Health Services, and we meet every 3 months to review the data and to look at the portfolio. And what I can tell you is heartbreaking, quite frankly, that data that we have gotten from, my wife is calling me. We are in Chicago and we have a reservation for a restaurant. But I can tell you that the data that was presented to us in 2018, 2019, 2020, the treatment gaps, and just to put numbers, 93% of those who suffer from any mental illness, plus substance abuse disorders in 2018, 93% of Latinos were not receiving treatment. 93%. 2019, 94%. 2020, 95%. We are going in the wrong direction. You know, I believe that in 2021 is going to be perhaps even worse than that. And between having access to mental health services or substance abuse services, those who are in need of substance abuse services are even worse, you know? So a lot of work has to be done in that regard.
So I'm going to quickly ask you two of the other remaining questions here, because I don't want to make you late for your invitation. And perhaps we can get to them. One is from Linda Seltzer, who says, how would you, concerning helping patients feel welcome, where do we go? How would you address medical centers forcing or pressuring people to electronically sign financial responsibility forms before having an appointment or on a hospital bed just before starting surgery?
Oh my God. Jeez. Let me see if I understand that one. Can you read it again?
Oh, sure. She says, concerning helping patients feel welcome, how would you address medical centers forcing or pressuring people to electronically sign financial responsibility forms before having an appointment or on a hospital bed just before starting surgery?
Ooh, I need to think it through, quite frankly. I don't have an easy answer to that. It's a great question. And if you please send it to me, Michelle, I will endeavor to think it through and send a response, if you don't mind.
Yes, thank you. And then the last question, and I'll mention I may send you one other one because I got a really interesting question from Gomo that I don't think we have time for. But this is from Jody Hassan, who asked a question before about rural population. She wondered, to follow up on her earlier question, if it's a largely white rural population, would that work also, who's just underutilizing mental health services? Or do you see this as primarily a vehicle for getting marginalized, say, communities of color, you know, to participate better?
Yeah, no, I believe that what I presented to you can be helpful for any population, including rural whites, you know, that are also facing inequities. In Appalachia, for example, you know, the opioid epidemic is a really prime example of the inequities that exist. Actually, what we experience in Solano County, what they report is that, you know, the changes that the system has made that has increased access and utilization of services for the three populations of focus has helped other populations as well. There has been an increase in some of the other populations. So it is like, you know, there is a metaphor. A rising tide lifts all boats, you know, that once you sensitize the workforce to work for you know, specific you know, populations of focus, other populations are going to benefit from it as well. I believe that this is what has been seen in Solano County.
I think that is a great note to end this webinar on. And I want to just thank you, Dr. Sergio Aguilar-Gaxiola, for your eloquence and your insight and your vision and your time today. And I want to thank our audience for all of their great questions. We'll be sending you a survey asking for your feedback on today's program and for your ideas and other topics of interest. We also urge you to help support these webinars. You can find more information on how to do that here. We'll be archiving this webinar a little later today at centerforhealthjournalism.org. And I want to wish everybody a very wonderful and healthy day. Thank you so much.